which are very important. It cuts across a lot of specialties. It's very important for emergency room, very important for internal medicine, and very important for ICU and cardiology. Because as we'll see in the presentation, this is a life-threatening condition, and detection makes a big difference in terms of outcomes. So what do you plan on learning today? The learning objectives for today's lecture: by the end of this activity, the learner should be able to identify the anatomy of the aorta, identify the different types of acute aortic syndromes, know when to suspect aortic dissection, identify the limitations of aortic imaging, and identify the management of aortic dissection, whether it's type A or type B, and know when to refer a patient for aortic aneurysm repair. And we'll go through each and every one of these points with some detail. So we start with a problem. So we have a 65-year-old female with past history of hypertension. She presents with sudden onset of severe chest pain. Blood pressure is elevated, 180/90. The remainder of the physical examination is unremarkable. ECG shows sinus rhythm with non-specific STT changes. So this is not an uncommon clinical presentation. This is something which you see in every day on a regular basis in the emergency room. So it's important to identify how you would approach patients who come with these symptoms. So the first thing you do with somebody who has severe chest pain is do an ECG to rule out an ST elevation MI. And in this case, the patient has sinus rhythm with non-specific STT changes. So that is going to be the problem. We're going to take it with us every step of the way as we see how we can manage such patients. So the first thing is to identify the anatomy. Now, as you can see from this diagram, the aorta itself can be divided into different parts. You're probably all familiar with the ascending aorta, the arch of the aorta, the descending thoracic aorta, and the abdominal aorta. Now, the thing that you should also understand more, which might be new for you, is to know the difference between the ascending aorta and the aortic root. These are two different things. The ascending aorta starts from the sinutubular junction and extends to the first branch of the aorta, which is usually the right brachiocephalic artery. The sinutubular junction extends from the junction of the sinuses of Valsalva and the ascending aorta. The aortic root then ends at the sinuses of Valsalva, and this is going to be the measurement at the levels of the sinuses of Valsalva. The aortic valve itself sits at the level of the aortic annulus. So whether the aortic root is involved or not will determine what type of surgery the patient gets in the event of an ascending aortic dissection, as we will see later on. The aortic arch is where the branches come off. It ends at the left subclavian artery. Then you have the descending aorta, which is thoracic, and then after the diaphragm, it becomes abdominal. Now, this is also important to know that the abdominal aorta is divided into infrarenal and suprarenal. Suprarenal means it's above the kidney, above the renal arteries. Infrarenal means it's below the renal arteries. And this demarcation will also determine how you treat it. So infrarenal abdominal aortic aneurysms can be readily treated with EVAR as long as they are below the renal arteries. Once the aneurysm is above the renal arteries, then the repair is going to be more complex. So that's as far as the different parts of the aorta, and that's how they are defined in imaging. It's important to note that the aorta's diameter is should be less than 40 millimeters. As far as the thoracic aorta, it should be less than 40 millimeters. In any patient who has, and this applies to most patients, it's important to understand that the aorta, the size of the aorta depends on the patient's body surface area, their age, and gender. So smaller patients, females, younger, have smaller aortas than larger male patients, and as people age, the aorta gets bigger. Okay. Now, as far as the acute aortic syndromes, there are three types. The most commonest type, and the focus of this presentation, is the acute aortic dissection. It's important to note that the key abnormality in all acute aortic syndromes is that you get disruption within the media. And aortic dissection, there's going to be a communication between the lumen, the true lumen, and there is formation of a new false lumen. Acute intramural hematoma happens when you have bleeding within the media. A penetrating aortic ulcer is when you have ulceration that does not form a false lumen. All of these conditions have one thing in common, that they're all going to be painful, and they're all treated very similar way. This is aortic dissection is by far the commonest, but the other two are things you see when you suspect a patient to have aortic dissection and you go through the imaging, and then the imaging diagnosis comes showing something different. The management is very similar, as we'll see later on. Here we see, this is an example of a picture of aortic dissection by MRA, magnetic resonance angiography. The key, you see two lumens here. So you have a lumen in the inside here, and then you have a lumen on the outside here. Okay, so aortic dissection, you get an intimal tear leading to formation of false lumen and true lumen. Now, I think just to get feedback and make this interactive, the question I have for the audience, which is the true lumen and which is the false lumen, and why? And Mohammed, Mazin, I think you can have them.
حاضر. ممكن يا اما بالريز هاند او بالشات فانكشناليتي. شايف احمد قال inner one.
Okay, and excellent, very good.
وشيماء برضو قالت inside one.
Okay, excellent. So you answered this answer correctly. So why is it the inner one?
وايدنس. احمد قال لك الوايد العرض بتاعه.
So the wider one is the false lumen or the true lumen?
شايف عثمان محمد علي قال لك the part that took the most dye.
Yeah. So the key thing is the branches. Okay. So the branches are the ones that tell you true lumen from false lumen. Usually the true lumen is smaller, but really it's the presence of branches that show you the difference between a true lumen and false lumen. And this applies to most concepts of vascular interventions and vascular imaging, even in people who do coronary interventions. And that's important for our cardiology fellows who do cardiac cath. If you have branches, then you know you're in the true lumen when you're doing an intervention. So the true lumen is always the one that has branches. And as you can see here, this one has branches. Okay, so as far as epidemiology, it happens, and this data comes from the Oxford Vascular Study. I think at the end of the presentation, we'll share with you all the references so you can read separately. It happens 6 per 100,000 per year. So if you're working in a busy emergency room, which sees 100,000 patients per year, that's going to be a busy one, obviously, you can see up to 6 patients, assuming that you have a similar population. So it's not uncommon. It is something you see a few times a year if you're really busy, and if you're not so busy, I guess you can see it once a year. Mean age is 63 years old, and 65% is more commonly happening in males. Now, as far as the epidemiology and risk factors, pre-existing aortic disease, pre-existing aortic valve disease like bicuspid aortic valve, history of cardiac surgery, smoking, are all factors that predispose you to develop aortic dissection. Direct blunt trauma can be a cause. Then there is the IV narcotics, specifically stimulants, cocaine and amphetamine. You get, these are stimulants and they are more likely to cause aortic dissection. Note that opiates are not in that group. Associated conditions, and this is a very attractive question for exams like the MK-SAP or the MRCP exam. They will want to know testing your knowledge if you know these things. They're fairly rare. Marfan syndrome, Loeys-Dietz syndrome, Ehlers-Danlos, and Turner, where Turner is more associated with coarctation. Then aortitis, like giant cell arteritis, Takayasu arteritis, and Behçet disease. These are all causes or associated conditions with aortic dissections. Obviously, for these above syndromes, there's going to be some other signs that will tell you whether or not which can give you a clue to the diagnosis. For the inflammatory conditions, there's going to be associated inflammatory changes as well. Moving forward, there is 3 types. There's 2 classifications of acute aortic dissection. There is a DeBakey classification, and then there's a Stanford classification. For the Stanford classification, it's simpler. Type A means ascending aortic dissection involvement. Okay, so A is for ascending, B is for descending, and that is the most important differentiation in terms of the management. Type A is a surgical emergency. Type B is a medical emergency, unless it gets complicated, as we'll see later on. Now, as far as symptomatology, now the data we have for aortic dissection comes from something called the IRAD registry. The IRAD registry is something which is developed and led by University of Michigan. It's 12 centers in Europe, which enrolled all patients who have acute aortic dissection as a registry. And from that registry, most of the data that we know about aortic dissection comes from there. The key thing to understand is that there are 3 symptoms that when you see them in a patient, you should suspect aortic dissection. The first thing is the onset of the pain. 85% of patients who have aortic dissection, whether it's type A or type B, have sudden onset of chest pain. And that's very important. So that's where you need the history. And it's chest pain in most cases. If it's descending, it can also come with back pain. So the onset of the chest pain is a very important component of the history when you suspect a patient with aortic dissection. Now this, and as long as you understand that this is sensitivity, not specificity, it makes, the absence of chest pain does not rule it out, but the presence of chest pain makes it more likely if you're looking for that diagnosis. Okay. There are other complications which can be associated with aortic dissection, and these are generally associated with worse prognosis and worse outcomes. So if you have somebody who has ascending aortic dissection and they get aortic regurgitation, that means that the dissection has extended below the sinutubular junction and into the aortic valve. And then that will mean that the surgery is going to be more complex. So these patients are going to be sicker, they're going to be hypotensive, and they might have bled into the pericardium where they develop cardiac tamponade, and they're generally very sick. As you might know, that once the dissection extends, it's more likely to involve the right coronary artery, and that can be an inferior ST elevation MI. And that would be, that is something that happens as a complication of the condition. Myocardial ischemia is generally defined by elevated troponin. You can get elevated troponin in type B aortic dissection. That's why this can overlap with the 2 groups. The other complications which are shared by both type A and type B are presence of pleural effusion. This could be either because of inflammatory response, or it could be because in the case of thoracic is perforation into the pleural cavity, which is obviously a very dangerous situation to be in. Acute renal failure, mesenteric ischemia, and spinal cord injury can all happen. So that's why when it comes to the physical examination, you may be able to detect an aortic regurgitant murmur, but that will be difficult to find out and to confirm. You'll probably be needing an echocardiogram to diagnose aortic regurgitation in this context. Now, coming to this slide, and this is very important because it gives you an understanding of how to clinically assess for aortic dissection. As you can see, this is a study that came in 2011, and it was based on the IRAD registry. So what they looked at, they found that there are 12 things that really increase your sensitivity for detection of aortic dissection. And these are the 3 ones that go down to the history. So the history is critical for aortic dissection. Abrupt onset of chest pain, which is severe, and a tearing pattern. Note that 70% of patients who have aortic dissection will say they have abrupt onset of chest pain, abrupt onset of pain, which is severe. So that's very important differentiation when you assess a patient who has chest pain. The chest pain is sudden onset and it is severe. Obviously, there are other things that can cause it, but once you rule out those other things, that's when aortic dissection comes into your differential. Other findings which are actually, which you may find, which can happen, will help you diagnose aortic dissection, but they are less likely to happen. If you find that they look like Marfan, but most patients don't look like Marfan. Very few patients have family history, and very few patients who have aortic dissection have non-aortic valve disease or recent aortic manipulation or thoracic aortic aneurysm, which is known. You can find other things like a murmur of aortic insufficiency. and that can happen up to 25% of patients. Hypotension and shock 16% of patients. طيب مازن نجيب في دي بس نتاكد انه الناس وقعت لهم البوينتس دي قبل ما نمشي للبعض.
جدا. شباب في اي سؤال او استفسار بخصوص الماتيريال اللي تقدم لحد الان؟ ممكن نستعمل الشات فانكشناليتي او الريز هاند، يعني او الكويستشن اند انسر برضه زي ما استعملناها حقبه. صفا طيب. صفا؟
Yes.
عندك سؤال؟
I have a comment. If I may start with Assalamu alaikum. I think that's an excellent exercise for everybody. I'm not quite sure what's the number of the audience, Lakin that is a very thrilling presentation. Yeah, Dr. Salah, I must congratulate you on it. I just have a comment, if I may. Pass it as a top up on what you've already said. I think clinical examination is the most important part of suspecting this fatal disease, otherwise fatal disease. The history of a tearing, sudden onset of pain. It's a tearing pain. It's just as if a knife is being pulled across the chest and goes to the back. That's almost a description given by each and every single patient with acute aortic dissection. So you were right. I mean, history comes very much top onto suspecting it. But I would like to raise a hand and a flag for clinical examination. In your series, 25% of patients have a new onset aortic regurg murmur. Now, I wouldn't claim that I have a huge experience with those patients, but the few aortic regurg murmurs that I've heard in the patients with tearing chest pain that turn out to be aortic dissection is a classical blowing early diastolic murmur that you cannot miss. You just have to listen to it. You just have to suspect it, to listen to it. The other important sign is you take the pulse not on one side. You take both radial pulses, and very, very often they are unequal. So a patient with a tearing pain, sudden onset, with inequality of pulses on the radial side, on both sides, and a chest examination or recorded examination that reveals an early diastolic murmur, diagnosis number 1, number 2, and number 10 is aortic dissection. And believe me, if we sweat a bit to get those signs, they are probably present in more than 50%, not the 25% already in the series. I would like your comments, Salah, على الكلام ده.
Yeah, thank you very much. I think it's very important, Mazin, to introduce Dr. Safa. Dr. Safa Mohammed Hassan Al-Tayyib, senior cardiologist, imager. She was in Sudan Heart Center for several years and now in Saudi Arabia. She's been very passionate about education and training of cardiology fellows in Sudan. I think we're really honored to have her with us today. And Jerry, thank her very much for her time, which is she's been very generous over the years in giving it. Thank you very much, Dr. Safa, for coming.
شكرا لك دكتورة صفاء. شكرا لك على الكومنت وعلى المداخلة، ونحن دائما سعيدين انه يكون معنا اكسبرت في الفيلد. دكتور صلاح، لو عندك في سؤالين يمكن من الاودينس برضو. في واحد كان I think it's a little bit important انه how to differentiate between dissection and pure inferior MI if there is no echo facility, if you're working in an area that is not as advanced. So
yeah, so this is I don't think you can tell. So many times, so the case is that the way you're going to tell them apart, so if you have somebody who comes with an inferior ST elevation MI, who has abrupt onset of chest pain, so obviously they have the same clinical presentation. If that is an extension of an aortic dissection, then it's probably later on in the presentation. So he's already presenting slightly late. Obviously, the patient brings you see the patient with what you see. Usually you can tell these two apart if you're doing a primary PCI. So if you're doing a primary PCI, obviously, then you can see a dilated aorta when you're doing the procedure, and that will be your clue that this is not the regular kind of inferior STEMI. It's not inferior STEMI because you have a ruptured plaque, but it's inferior STEMI because the dissection extended down into the heart. Obviously, echocardiogram will tell you the difference between the two because you'll be able to see that dilated aortic root and the pericardial effusion, which is commonly associated with that. If you don't have an echo, and you don't have, if you do not have an echo and you do not have a CT scan, and you're faced with a patient who has an inferior ST elevation MI, then probably the biggest clue you can get is a chest X-ray which shows a dilated mediastinum. You shouldn't see that in somebody who has an inferior STEMI. Now, the definite challenge will be if you have somebody who has an inferior ST elevation MI and you end up giving him thrombolysis when he has an aortic dissection. Because in this context, the thrombolytic agent will make everything worse. Okay, but thankfully, hopefully, you don't get a lot of these patients. But one clue might be that they are in extremis and they're extremely hypotensive and in a very critical situation.
طيب ده برضه بريد السؤال اللي بعده دكتور صلاح انه عن البلد بريشر. شايف في كم سؤال انه is normal blood pressure common or should it be hypertension, hypotension?
Yeah, so that's the thing. I think it's we associated. So as you aortic dissection, if we go back in the slides, so one of the things that as you can see, there is no mention of hypertension as a risk factor. Okay, and also if you look here, hypertension itself is not something that makes you suspect the diagnosis. So hypertension is commonly associated with it, but it's not something that helps you for the diagnosis. So you can't say, okay, this patient has high blood pressure, then he has aortic dissection. You can't say that. So if you have hypertension, it's a risk factor for a lot of things, like coronary artery disease, or it could be just a stressor of being in pain, will shoot your blood pressure up. So hypertension can happen in patients who have aortic dissection. So that's one thing. Hypotension, low blood pressure, when you have it, is a dangerous sign because that is a shock state. So as far as the blood pressure is involved, it doesn't help you in the diagnosis, it helps you in assessment of severity. Does that answer the question?
في تاني دكتور صلاح سؤالين I think they're more suitable to the end of the presentation عشان not to steal the thunder لو انت حتمر عليهم.
اوكي تمام. طيب اوكي انا هحاول اعلي صوتي. هل صوتي كده واضح ولا في ناس قالوا الصوت واطي مش؟
ايوه شايف في كومنتين انه الصوت واطي. فشباب لو سمحتوا بس واحد يعلق لنا في الدردشه. هل الصوت الان واضح من دكتور صلاح؟ good it's good دكتور صلاح.
الصوت واضح. اوكي طيب نرجع تاني للبروبلم حقتنا. اوكي so we talked about this lady. She's 65 years old. She has severe chest pain. She has high blood pressure. طبعا this is a real case. So she came in sinus rhythm with non-specific STT changes. And this is her chest X-ray. So what do you see and what would you like to do next?
Okay, في تعليق وايد ميدياستاينم من محمد.
Exactly, right? So now you're kind of getting closer. So then becomes the question is, what do you do next? So the next step depends on the facilities you have, right? So for you to diagnose aortic dissection, you must have one of two things. Either you have an echo or you have a CT. And the availability is there, but it might be difficult to get it, but it is available. So the transthoracic echo has advantages. Now, it's important that, especially for the emergency room doctors and the internal medicine doctors, you need to know the test and its limitations, because the limitations of the test will help you guide you towards making the diagnosis. So you have somebody who's coming in with severe chest pain. You've done the EKG, the chest pain of sudden onset, severe. You've done the ECG, and you see no ST elevation MI. Okay, you don't see anything that tells you it's an acute coronary syndrome, apart from the symptoms. You do a chest X-ray, which may or may not show widening of the mediastinum. You're suspecting that the patient has aortic dissection, or the second differential is pulmonary embolism. These are the two big things that you want to rule out, right? So you have two tests which can help you. Transthoracic echo for aortic dissection has the advantage of being relatively easily available. You can do it at the bedside. You don't need radiation. You're not going to expose the patient to radiation, and you're not going to expose them to nephrogenic agents. Now, the problem is you can see the ascending aorta by echo, but you cannot see the aortic arch, and you cannot see the descending aorta. So if you do an echo transthoracic, and you're suspecting the patient to have aortic dissection, and you see that the ascending aorta and the aortic root are fine, it does not mean they don't have it, okay? So that's one thing. CT, on the other hand, gives you superior visualization. You can see the whole thing. You can see everything from the aortic annulus all the way down to the descending thoracic aorta and the abdominal aorta. So you see everything. The downside is it involves radiation and it is nephrotoxic if the patient has an abnormal creatinine. Transesophageal echo has less availability. You need to get somebody who can do it, who's trained in doing it. So it's going to have less availability. But it can be done at bedside. So if you're in the emergency room and the guy is already on life support and his blood pressure is very low and it is not safe to transfer him for a CT scan, then at that point you may consider doing a transesophageal echo. It does not have any radiation or nephrotoxicity. You may not see the aortic wall arch very well, even if you do a TE. But if the patient is intubated, it's usually easier. It also, as far as the MRA is very good for follow-up. It's difficult to get it. All the time, especially out of hours. فأفتكر Mazin, since Dr. Safaya, she's an expert in imaging, I think she may comment about this part.
دكتورة صفاء ممكن تتفضلي. أنا طبعا فاتح لك التوكن functionality. You can just unmute yourself.
طيب سامعيني كويس؟
أيوة صوتك واضح دكتورة صفاء.
طيب that's very good. And what I like best about this, yeah, Dr. Salah, إنك you started off with the chest X-ray, which is an underused, very robust imaging modality, which can tell us a lot, especially زي ما قال الدكتور قبل, there might not be availability of most of those يعني elements من echo ل CT ل MRI. Now I have a great passion for echo, and that's what I kept telling everybody. لو قدرت تمسك البروب وانت في emergency suite to tell whether this is aortic dissection or right ventricular strain due to massive pulmonary embolism or a large pericardial effusion, we would be happy. This is one of the situations where echo has to be learned and known by heart by every single fellow, at least for level 1. You cannot practice and a cardiology setup to not to answer this question whether this is dissection or not. Almost 90% of aortic dissections, especially the serious aortic dissections, can be seen, visualized, and diagnosed by transthoracic echo. And believe me, it doesn't need much of an experience. On the other side, the CT scan, which is, if you ask me, is a modality of choice. I have seen quite a handful of aortic dissections which has been wrongly diagnosed by CT because of interpretation of some images faults as a query flap. And I've seen patients taken to the OR and the chest is open and there is no dissection. It just tells you one thing. There is not a single one parameter that just take the whole thing. You have to get the whole thing from history to assessment to imaging. So for me, the best one, start with the chest X-ray, and that numbers would add up. Clinical examination, history, chest X-ray, widening of the mediastinum, echocardiogram, especially the transthoracic. I haven't done a single TOE in a patient with aortic dissection for 2 reasons. Most of the time, a transthoracic was very informative, and we were lucky in most of the situations, especially if the Sudan Heart Center, we had a CT scanner nearby, and we used to scan the patient. So I didn't need to pass the probe. Thanks God, لأن you know, عشان to pass a probe, a transesophageal echo probe, the patient in aortic dissection, he really has to be ready to go to the theater. لأنه with the introduction of the probe, you can extend the dissection flap.
Yeah.
شكرا.
Thank you very much, Dr. Safa. It's great to have you. طيب نمشي to the next one. Okay, so this is it shows you some of the lab changes you may see in patients with aortic dissection, and generally laboratory tests are not going to help you diagnose. They're going to help you assess. Hemoglobin and red cell count, white cell count, CRP may be elevated. Procalcitonin may help you to differentiate it from sepsis. Troponin is going to be elevated whether they have aortic dissection or pulmonary embolism or they're having a coronary event. So troponin does not help you differentiate. It helps you know to assess their risk and the severity of their condition. The dimer can be elevated, so it may not help you it doesn't help you with diagnosis of pulmonary embolism. Creatinine is important as you're going to do imaging. The liver enzymes, as they're involved, lactate for bowel ischemia, and then if you're looking for associated conditions, and the blood gas for severity. So the role of laboratory investigations are not going to help you differentiate it from acute coronary syndrome and pulmonary embolism. Okay. Okay, so now we move forward to discuss the medical management. Every patient with aortic dissection, once you establish the diagnosis, you have to do this. Control their pain, and that is by opiates. You don't need to give them morphine, pethidine, or fentanyl, depending on what's available to you. Don't give them a non-steroidal anti-inflammatory drug. And Tylenol and acetaminophen, Panadol is not going to be enough. IV paracetamol is not going to be enough. Give them opiates, it's painful. Blood pressure should be controlled, and your target is 120/80. This is one of the few conditions where you really want the blood pressure to go down. And that should be done by an intravenous agent. Now, obviously, دي بعدك بنخش في صعوبات السودان مش؟ لأنه أفتكر الاي في بيتا بلوكر اي في ازمرول ده ما متوفر. الاي في ميتوبرولول ممكن يكون متوفر لكن نادر. And even then, it only lasts for a few minutes. So that's where you might have difficulties. Vasodilators would be your second line as far as the agents used to reduce the blood pressure, and these in the form of nitroprusside and nipride and so on. Obviously, in order to achieve that target blood pressure with an intravenous agent, you just have to do the most you can. You may end up giving oral agents, but try to do as much as you can to bring that blood pressure down. And that applies for type A aortic dissection and type B aortic dissection. You have to bring the blood pressure down. You have to bring it down quickly. Your target is 120/80 with an IV agent as much as you can. Okay. Now, as far as type A aortic dissection, so I'll go back to differentiation between type A and type B. So type A is when you have involvement of the ascending aorta. This is type A. Okay. Type B is descending aorta. Type B is descending aorta. Okay. So for type A is a surgical emergency. If you don't operate on this patient, half of them will die in the first 48 hours. Half of them will die in the first 48 hours. So that's why when it comes to seeing a patient who's got this condition, you have to bear in mind that if you do not do the surgery, this is very urgent, right? This is not something that can be postponed. You have to do it. دي ما حاجة ممكن يركبوا لها طيارة. Okay, you have to do it, and you have to do it where you are. So that's why it's important to diagnose. It's important to treat. At the first month, it becomes 90% mortality. Very few things have a 50% mortality. Okay, very few things have 50% mortality. Cardiogenic shock is in that group. Stent thrombosis is in that group. As far as the surgical outcomes are not that great. So, but it's much better than not doing anything. So medical management for patients with type A aortic dissection has a 50% mortality. Surgical management has a much lower mortality, but you can still die. Okay, so يعني عيان جاك عنده type A aortic dissection وديته الاوبريتنج روم ومات، دي ما بالضروره ما تقول الجراح يده ما نظيفه ولا المستشفى كعبه، لا. This is 22% in excellent hands. Okay, the fact that you took him to surgery does not mean that the surgery killed him. Okay, the reason he died is because he came with a very bad condition. But it's very important when you communicate the expectations with patients. 18% may have neurological complications. Okay. Like the type of surgeries, and these are kind of more for, it's more of an academic exercise. The surgeons will be much more interested in discussing this at depth. But if you have involvement of the ascending aorta only, without involvement of the aortic arch, and without involvement of the valve, you do an ascending aorta replacement. If you have involvement of the aortic valve, then you have to replace the aortic valve, and that's called the bent valve. And this will be more of interest to surgeons. If you have involvement of the arch, then you need to do an aortic arch replacement and ascending aorta replacement. And if you have involvement of all of this, then it's a very heavily invested procedure. And this is associated with the complexity of the condition. Like, type B aortic dissection is treated medically unless the patient develops a complication. Okay, and what is a complication? It means that the patient is developing signs of rupture. And that's by serial CT scan. So if you did the first CT scan, the patient has aortic dissection, and then you follow it 2 days later and you found that this thing is expanding, that would be an indication for intervention. If the patient has persistent pain in spite of control, in spite of giving him analgesics, and in spite of controlling the blood pressure, then that would be a surgical indication. Or if the patient starts developing malperfusion, renal ischemia, mesenteric ischemia, and things like that, then you need to intervene. The way you intervene is by surgical or by endovascular repair. All right, so now we continue to this lady, and this is a real case. It's not, this is a real case from Sudan. So as you can see, the patient had an echocardiogram done, and it showed that there was massive dilatation of the aorta. As we said earlier, the normal caliber of the aorta should be about 40 millimeters, right? So you can see here that this is 67 millimeters, so this is very dilated. And then you can see, actually, you can see a hint of something here. So when you do the cine loop, if I loop this and enlarge it, so as you can see here, this is a dissection flap. This is a dissection flap, and this is, so this is, just to orient you, so this is the mitral valve, this is the aortic valve, and then you have the aorta coming out of the aortic valve, and here is, you see the dissection flap. So our patient here has ascending aortic dissection, ascending aortic dissection. So as we said earlier, the management is by doing surgical repair. So this patient was actually taken to Sudan Heart Center, and this is a surgeon's view. So imagine that this is the head of the patient, right? So the head of the patient is going to be here. This is going to be the body of the patient. So what you're seeing here, this is the aortic root here, roughly speaking, and then this is the rest of the aorta. Okay, so this is relatively massively dilated because it has aortic dissection, and the patient underwent this type of surgery. Okay, so just to so any questions about aortic dissection before we go forward to the rest of the presentation?
طيب دكتور صلاح، في سؤال كان عن الاي في فلويد رول في المانجمنت. هل البيشنت محتاج اي في فلويد؟ should it be avoided?
Yeah, it depends on how they're doing. And if the patient has an ascending aortic dissection which extended into their you know, if they developed you know, dissection in the RCA and they went into heart failure, you may not want to give them fluid. But if you're resuscitating them for hypotension, then obviously you may need to give fluid. So the fluid depends on the clinical context.
Okay. وفي سؤال ثاني كان من أحمد نور، كان earlier on عن intramural hematoma. Is it treated as dissection or is it a separate entity as far as treatment algorithm?
Yeah, so as far as the treatment is very similar. So these are less common conditions, and I think we're going to go. We have a couple of slides about them that we're going to go into. في حاجة في dissection that we need to address now.
Okay. There are questions اللي عندي حاليا.
Okay, طبعا. طيب, so there's two other forms. This is not as common. So usually the patients, you see them, they come with pain. They come with abrupt onset of chest pain or back pain if it's descending. And then you do the ECG, you don't see anything. You do the X-ray, you don't see anything. And then you do a CT scan, and then it comes with an acute intramural hematoma. So the diagnosis is by CT or MRI. You're not going to see this on echo. And the management is similar. Okay, so if it's ascending aorta, then you're going to do surgery. If it's going to be descending aorta, then you're going to do medical treatment, and you're going to follow it with CTs. Okay. Penetrating aortic ulcer is when you have a plaque, and the plaque has penetrated into and disrupted the internal elastic lamina. So as we know, plaque is the three layers of the aorta. There is the intima, the media, and the adventitia. So the plaque is located in the intima, and then what you have is ulceration into the media and development of some thrombosis, like you'd see in a coronary vessel. Again, this is diagnosed by CT and MRI, and you treat it the similar way to aortic dissection. All right. Now, this is one of the other, it is associated with acute aortic syndrome, and that's having a rupture of an aneurysm. This is different from dissection. Dissection, you have a true lumen and a false lumen. And that is how you make the diagnosis. Okay? When you have contained rupture is when you have an aneurysm and the aneurysm rupture. Yeah, this is exactly what it is, you know. So you have an aorta, the aorta ruptured, and then you have bleeding outside. Okay, so this is an example of an aneurysm, and the aneurysm has bled outside. So the darker color is blood, which has been contained by the surrounding tissue. That's why the patient is alive. If this happens and is not contained, it's sudden death, right? You diagnose by CT and MRI, you need urgent repair. The outcomes are really bad, 50% at 6 hours. نحن قلنا earlier for ascending aortic aneurysm is 50% at 2 days, 76% at 24 hours. That's why you want to prevent this. How do you prevent it? Is by operating on these patients before they reach a certain size. And that is a size you can, probably we're going to give you these slides so you can, this is something easy to keep, so you know it. If you have an ascending aorta, then you're looking at a diameter of 45 to 55, depending on the condition. If the patient has Marfan, you're going to operate earlier. If the patient has bicuspid aortic valve with high risk features, the definition of high risk is if you have FSCAI or if it's growing fast. If the patient does not have these two risk factors, the number is 55 millimeters. And that's the same number that you carry down, okay? And this applies to patients who are incidentally found. So you do a CAT scan, and this is something that you face in practice. You do a CT scan for something different, and you find an aneurysm. It's important that you don't forget about it. The patient is asymptomatic, right? He has a 50 millimeter ascending aortic aneurysm. You have to tell him not to ignore it. دي ممكن يعني تركب طيارة وتمشي ويعمل لك عملية وكده and prevent you from going into a catastrophic rupture. This is something which is important for you to advise the patient, and it's important for the patient not to ignore it because it's treatable. If you don't treat it, you end up with rupture and you will die. Most people will die. Okay. That was the last slide. There's a couple of references here. These have the guidelines and some additional articles. And I think we can probably share the link with the group, and we can take some questions.
طيب، بالنسبة للشباب المتواجدين لو في أي أسئلة حابين توجهوها لدكتور صلاح، بعدها حندي دكتورة ندى فرصة تدينا closing remarks، وبعد ذاك ندي دكتور صلاح المايك عشان يدينا الكونكلوجن والتيك اواي lessons.
في قصدك دكتور صفاء مش؟
أيوه.
معانا برضو دكتور أسامة عبد الحي. أسامة he's head of the emergency room at التميز، فافتكر برضو if he can give us some remarks.
حاضر. طيب I think مسافة تجي الأسئلة ندي دكتورة صفا الفرصة. أول حاجة دكتور صفا just hit unmute وتفضلي.
That was excellent, Salah. I think that was very enjoyable. اللي هو السهل الممتنع. You've done an excellent job. I must congratulate you. But one point that I should always, I keep reminding myself and keep reminding everybody, the aorta is a tubular structure. And if you depend on echo for follow-up of the diameters of the aorta, especially the aortic root, in patients with bicuspid aortic valve, to see how often it progresses and to decide about the timing of surgery, remember that it might enlarge in a way that you cannot detect on echo. But if you are diagnosing a patient as a bicuspid aortic valve with aortopathy, the best way to follow those patients up is on either a CT or MRI, not echo. لأنه الecho unfortunately is two and sometimes three-dimensional, but you have to know that this is the tubule that goes here and there, and you might miss the areas which are bulging out and might burst, causing a hematoma, especially you know that the aortopathy is a very complex structure on the bicuspid aortic valve. So I just wanted to alert everyone to this. If you want to follow up, echo might not be the good option for a high-risk group of patients.
شكرا دكتورة صفا.
أسامة ممكن يخش؟
دكتور صلاح معنا؟
أي أسامة.
ايوه انا عملت دكتور اسامه، انا عملت لك برضه التوكن فانكشناليتي، بس اعمل انميوت وتتفضل طوالي.
احتمال يكون في كونكشن هذا.
فتح شايف.
السلام عليكم، انا دكتور اسامه الحي.
تفضل
ايوه
دكتور، سامعينك دكتور اسامه، تفضل.
صوت واضح؟
ايوه
هاي سمعناك اسامه، هاي تفضل. شكله دي
والله؟
هاي سامعينك، هاي تفضل. هاي
استفادت جدا، وانا متاكد المره الجايه ان شاء الله عددهم حيزيد اكثر واكثر. وبالنسبه لي دي اول مره استخدم الزوم ابلكيشن، وحوريهم ان شاء الله في المرات الجايه كيف how to download and how to يعني to make use of it. فمشكور يا صلاح، وكما عهدنا بك دوما يعني supporting التريننج في السودان، supporting الريجسترار especially those of emergency medicine، وهم برضو شاكرين جدا لك، مشكورين جدا.
تسلم كثير اسامه. طبعا اسامه انا واسامه دفعه يعني we go back a long time يعني. فهم طبعا الشباب بتاع الميرجنسي روم بالمناسبه
ايوه
دكتوره صفاء they are trained in doing echo. فحتى حضروا الكورس بتاع الدكتور عباس خضر بتاع الكريتيكال كير ايكو كارديوجرافي. they know how to do.
ما عارف انا بديت ما سامع هل الشبكه.
هاي افتكر ممكن سامعني يا مازن؟ السلام عليكم، سامعني؟
انا سامعك دكتور صلاح، معلش انا
انا افتكر اسامه خطه بقطع شويه. فالعموم بالنسبه للشباب بتاع emergency room they're trained in echo and they know how to do basic echo and they do a great job with it and it helps them a lot يعني. فعشان كده من الحاجات برضه الناس ممكن تفكر فيها انه how to train the front line providers in doing echocardiography، خاصه مع limited number of cardiologists. مرات كثيره الايكو ماشين بتكون فيه لكن ما في cardiologist، فدي من الحاجات اللي ممكن تتعالج by training. طيب افتكر كان في few questions هنا. طيب انا ظهرت لي في الشات فاي كان انسر ذم يا مازن.
اتفضل تفضل.
We haven't IV beta blockers. What can we do to help the patient? You do what you can. يعني ما عندك IV agent بس تعرف الهدف. Bring the blood pressure down to 120/80 by any means. تديه analgesics، تديه IV agents اللي عندك، ما عندك IV agents تديه oral agents and so on. طيب Marfan operate at 4.5. Yes. Now the reason behind that is Marfan have a high predilection or high tendency to develop aortic dissection at smaller diameters. Okay, that's why the guideline changed for Marfan. طيب difference between inferior MI and aortic dissection. So inferior MI can be a complication of ascending aortic dissection. So differentiating the two might be challenging. Okay. طيب النوتس عن اكسريز حترسل للناس. aortic AR means valve replacement. وين دي؟ ما دي جات.
I think قاصدين بس الاكرونيم بتاع AR انه aortic regurgitation يا اسون.
اوكي. لا هاي دي قلنا ما استعملتها ذاتي. Anyway, yes, maybe I think so. طيب الصوت ما خالص، احتمال ذيك صوتي انا كان واطي شويه. Should we need to keep it less than 100 to avoid tachycardia? This is an aortic regurgitation. Yeah. So sometimes like عندك acute aortic regurgitation بتكون انت ما داير to prolong diastole. ده سؤال طبعا it's an advanced question شكله it's a cardiology fellow question. What about the heart rate? Generally speaking, aortic dissections are going to be tachycardic or they may not be. If it's aortic dissection not involving without regurgitation, you don't have to worry that much about the heart rate. You don't have to do anything specific to it beyond management of the underlying condition. In somebody who has acute aortic regurgitation, you worry about beta blockers because you're going to prolong diastole and you're going to prolong the regurgitation. الحاجات الزي دي don't worry about it too much. ليه؟ لأنه الزول ده المفروض يكون في الأوبريتنج روم. Okay. يعني انت عندك عيان عنده acute aortic dissection which is involving an ascending aorta ودخل في aortic regurgitation, don't worry too much about حكايه الدقيقه تدوم مع الدقيقه. الزول المفروض يكون في الاوبريتنج روم. اي حاجه تعملها بتعطلك من الاوبريتنج روم is harmful. عشان كده دي مهمه في البرايورتايزيشن. العيان ده عنده ascending aortic dissection لازم يمشي لجراح بيقدر يصلحها له. and he must do it very quickly. لانه اذا ما عملها خلال 48 ساعه العيان ده حيموت. كويس؟ فدون وري. يعني الحاجه الثانيه ما مهمه. You do the medical manual we talked about. تمام. افتكر
في سؤال دكتور صلاح في الكيو ان اي عن الرول اوف ستنتين تايب بي دايسكشن.
عنده رول لكن شنو؟
little bit advanced you think?
Very advanced حتى beyond the radiology fellowship training. يعني this is بيسموها T bar وعندها certain parameters that you have to use and it's beyond the scope of this presentation. لكن you can do it if you have it available.
اوكي.
الفيديو بتاعتك يعني. هذه الدور المتقدمة.
نديك في اي closing remarks دكتور صلاح ولا حاجه ولا؟
أنا أفتكر مشينا كويس في دي. أفتكر أنا very impressed أول حاجة by the fact that we got 47 people to get into Zoom. أفتكر I wasn't expecting it to be honest. But definitely thank you Mazin and Akram لأنه you did all the work behind the scenes يعني. وافتكر دي يعني الناس ممكن تشوف what is the best modality. وبعد ذاك أفتكر I think it's a great opportunity to educate people في السودان. وبعد ذاك I think you can do much more. Even as the COVID مشى يعني all these things change, I think this method will make you achieve milestones much better than before. فإن شاء الله يعني I encourage you to keep doing it and to expand it. والشباب إن شاء الله في السودان I know them firsthand. They are very eager to learn and they learn very quickly. فإن شاء الله يعني I think it will have a big impact.
طيب بس تنويه اخير لانه انا عارف في مشاكل كثيره حصلت مع جزء من الزملاء في اللوجن والزوم وكذا. في التليجرام بناء على طلبكم يا شباب عملنا قناه اسمها سابا ميديسين ريفيو، فحنتواصل معاكم ونشوف البيست موداليتي جوين فورورد عشان نسهل على الناس اكثر واكثر ان شاء الله. وبس تعملوا سيرش على سابا ميديسين ريفيو بتلقوا الشانل في تليجرام. بنشكر دكتور صلاح أبوسين على زمنه وعلى مجهوده وعلى الكونكشن اللي عمله معاكم في السودان وعلى البرزنتيشن الجميل ده، وإن شاء الله حنتواصل معاكم في البرزنتيشنات الجاية إن شاء الله. شكرا دكتور صلاح، شكرا دكتور صفا، شكرا للشباب الحضور.
السلام عليكم.